Hello, professional nurses. This is Mrs. Ignacio with our tutoring session for today. I'm going to be doing an overview of the nursing health assessment. This document that I'm using, there's hard copies that are located in the lobby for your convenience. Some of you do like to have hard copies, so there's many copies in the on the table in the lobby for you. So we're going to talk about health assessment. Okay, and this is one of the cornerstones of what we do as nurses, right? So when we think about assessment, I want you to think about the general health assessment. General health assessment is just an invaluable tool, and it begins when the patient walks in front of us or when we go into the room. So whenever we first see the patient, we are looking at them from head to toe. Are they walking or with an assistive device? Are they ambulating well? What is their gait like? Are they dressed appropriately for the weather? Do they look appropriate for their age? Do they look younger than their age or older than their age? Are they using any assisted devices? Do they have glasses, hearing aid, right? Do they have oxygen, any other supportive equipment? All of these things is what we're going to be looking at, right? Or how is their speech, right? So all of these things make up the assessment. And remember that your patient is going to be assessing you as well. So if you don't look very professional in your uniform, if you look like a bag of rags, they're going to say, wow, this is not going to be a good nurse, right? So remember, first impressions can be lasting impressions. Now, that doesn't mean that if you get off to a shaky start with a patient that you can't repair the relationship, but ideally you want to get off on the very best foot that you can. And when you're performing your assessment, you want to make sure that you provide for privacy and you want open and honest communication. And you're going to utilize therapeutic communication. So throughout this document, you're going to see test yourself. So it's just going to say, okay, do you understand the general concepts? So this first test yourself section says nurses use physical assessment skills too. And yes, obtain baseline data, enhance the nurse patient relationship, and it's all both of those, right? Both of the above. That's what we use our physical assessment skills for. Okay, so let's talk about the different types of health assessments. So in general, there's four types. So there's a comprehensive or complete health assessment, and we have the interval or abbreviated assessment, and problem focused assessment, and an assessment for special populations. So let's take a look at the comprehensive or complete health assessment. So this is usually performed in acute care settings, or if this is a new patient, you may actually have this performed during an annual exam, right, for a well child or an adult visit, right, to make sure that everything from head to toe is within normal limits. Now, if a patient has been under this doctor's care for some time, they may not have to do a complete health history. It's just going to say, okay, what has changed since the last time we saw you? Are there any updates, any new complaints, any issues? Okay, so that could be an internal or abbreviated assessment. The third type of assessment is problem focused. Okay, so what does that mean? Well, the patient may come in because they sprained their ankle. So you will immediately, after you check their vital signs, right, you will immediately go to a focused musculoskeletal assessment. So you have to use your nursing judgment to determine what kind of assessment you will use. So here's an example. If you are in a clinical setting and you are on a cardiac unit, I would expect that you're going to perform a focused cardiac assessment. Okay. And most times with the cardiac assessment, there will be a respiratory assessment as well. Now, the fourth type of assessment is going to be for special populations, and that includes our pregnant patients because there are things that are unique to our pregnant patients, infants, children, and the elderly. So, yes, your pediatric patients are very specialized, and so are the care for the elderly. Okay, when we establish a baseline assessment, this baseline is going to tell you where the patient is at this moment in time. Okay, so this is going to be just to establish a baseline to see where they are. Okay, and that's just going to be important. So you may hear baseline vital signs. We will take baseline vital signs before a patient goes off for a procedure. So when they come back from the procedure, we'll take their vital signs again to see if anything has changed. Okay. Now, when we talk about assessment, we have to understand the terms that go along with it. Okay, so there's going to be inspection, auscultation, percussion, and palpation. So you have to understand what each of those things mean. And when we are talking the nursing language, you have to understand what the words mean so you can be successful, because the test questions, the NCLEX is going to use nursing language, is not going to use lay language. So let's talk about inspection. So inspection is most frequently used, right? You are using, I wouldn't say your five senses, I would say probably three or four senses, right? Because you are observing with your eyes, your ears, your nose, because sometimes something may be malodoriferous, right? It may smell bad, right? And you're also using your sense of touch, but I don't think you should be using your sense of taste. So I would say three to four senses you'll use as you are inspecting your patients. So you're going to be looking for skin color, lesions, symmetry, right? So these are all things that you're looking, you're observing with your eyes, ears, nose, and even sense of touch. Okay, so this is very important. Inspection should always come first. You always have to look first, okay? So the most frequently used assessment technique, and this is to test yourself, right? The correct answer is B, inspection. We are going to inspect, inspect, inspect. All right, let's go to our second part of the assessment, which is auscultation. So this is usually performed following inspection, especially with the abdominal assessment. Okay, so auscultation is a fancy word for saying listening. So you will clean your stethoscope, right? So you'll clean the bell and the diaphragm of your stethoscope every time before you place it on a patient's skin, because you don't want your stethoscope to become a staffy scope, right? So just a little bit of nursing humor. All right, so you will clean your stethoscope and also clean the earpieces because you don't want to introduce infection into your ears, right? So you want to listen on the skin, right? We always should try to listen directly to the patient's skin. That's going to give you the best sound, okay? So and so that's really just the best practice, okay? Because if you're listening over the gown, there could be rubbing. If you're listening over the clothes, there could be false sounds. And so you won't really be able to hear the true sounds, okay? So that's going to be important. Remember, the bell of your stethoscope is what you're going to use for murmurs and bruits. The diaphragm of your stethoscope is going to be the side of the stethoscope that we use most times. Some of you may have a stethoscope that can spin around. I want you to closely look at your stethoscope, and there should be a little circle, and that little circle, it tells you what side you're actually listening to. So if you have a stethoscope that was given to you by the school, take a moment to look at it so you can actually see what I mean. Because I have encountered some students that didn't realize their stethoscope could actually twist around and can be used for the bell or for the diaphragm. The diaphragm is a larger circle. The bell is the smaller circle if you have a stethoscope that has a bell and a diaphragm. Okay, you may notice in this picture that it has what I call the zigzag pattern. And the reason why we're auscultating using this zigzag pattern is because we want to measure the sounds bilaterally. So on the left side of the lungs or the right side, is it going to be the same, right? Because we should have symmetry. And that's the same way when we're checking for pulses. We want to check both pulses, always bilateral. Okay, let's talk about palpation. So palpation is when we are depressing the patient's abdomen, right? Or maybe their back, right? So their muscles. So we want, what are we doing when we are pressing, right? We're not trying to cause the patient any pain or discomfort, but we're checking to see if there is any pain, any discomfort, any moisture, are there pulsations, right? Maybe there's a pulsating mass, right? So that's what palpation is really for, okay? Now, percussion, we are trying to see there's any sounds, right? When I think percussion, I kind of think of Sheila E. and I think of the drums, right? So when we talk about percussion, you're going to place your non-dominant hand on the excuse me, on the body part that you're trying to assess and percuss. And then you will take your dominant hand, that middle finger, and you will tap the first knuckle of that non-dominant hand. And so the sounds that you're trying to listen out for are going to be timpani, resonance, hyperresonance, dullness, and flatness. Now, based on the area of the body that you're percussing, you're going to hear different sounds. So timpani is going to be sounding like a drum. And I would expect to hear timpani over the lungs because they are actually filled with air, right? Um, let's see. Um, let's see. And then resonance is a hollow sound um, that there's a solid structure, right? And some air. Okay, so I'm sorry, I take that back. Timpani, I said was air pockets, so that's not true. You should have resonance. Okay, now hyperresonance is going to be like what you find in your emphysema patients because it's a booming sound because it's hyper, right? And this is going to be with your emphysema patients. Now, dullness is over solid masses. So if I were to percuss over the liver, I would probably hear dullness, right? Now, flatness is going to be heard over dense tissues like muscles and bones, okay? So depending on where you are percussing, you're going to get a different sound. So that's why it's important to know your anatomy and physiology because you're going to know that, okay, if I'm percussing on the right upper quadrant, I should get the sound of dullness. That's a normal finding because the liver is there, right? So that's kind of how you can think about it. All right, let's go to the health history. So when we think about the health history, we're going to be asking some questions. You probably have seen many forms. You may be familiar with the forms. We're going to find out the chief complaint. That doesn't mean that the patient is complaining. That's going to say, well, that the chief complaint means the reason why the patient is in the office today. Okay, so their present health status. Are they in excellent health, fair health, poor health? What is their past health history? What is their current lifestyle? Are they drinking alcohol, smoking cigarettes? Do they get exercise? What are their nutritional requirements? Or do they have a healthy diet, right? Also, their psychosocial status. Are they feeling depressed? Are they sad, right? Those are all things that we have to think about. Also, do they have a family history of cancer or of heart disease, right? These are all important things because we know our genetics do shape a good portion of what our health outcomes will be. It's not everything, but genetics, you know, you have your genetics and you have to live with them. But the environmental factors are things that we can control. And so we want to get a good picture of what's going on with the patient. Also, the review of systems. That's going basically through our 11 body systems and saying, did you have any surgeries, any complaints, any pains, anything going on? So when we talk about the systems, gastrointestinal system, respiratory system, nervous system. So that's something that we will document, right? The review of each of those systems. So here is a test yourself kind of question. So factors that impact your patient's physical status include spiritual needs, cultural idiosyncrasies, and functional living status. And yes, that is true. One of the things NCLEX is going to test you on is cultural competence. Are you able to understand a patient's culture or their religious background and respect that and then understand how it's going to impact their care? So that's going to be something that's really, really important. So the chief complaint, so we're going to get down into the details here. The chief complaint, tell me what you have, what brings you to the office today. So these are questions you're going to ask are open-ended questions, and really you're going to listen to what the patient is saying. You want to make direct eye contact. You don't want to be, charting and not looking at the patient, right? You want to really show them that you are concerned. Okay, so here's some of the questions that you may have asked, right? And so it's listed here. So if the patient has a number of complaints, you want to prioritize. What is the one that is bothering them the most? Okay. Now, when we talk about the present health status, one of the things that we're going to do is assess for pain. So, of course, we're going to take their vital signs, but we're going to assess for pain. So, what I need you to know is the PQRST of pain. So, if you hear that, if you see it on a test question, what is the PQRST of pain? So, the P stands for provocative or palliative. So, what makes it worse, this pain? Or what makes it better, right? So we have to ask that question. Okay, so maybe sitting down makes it better, or maybe it continues if they're sitting or moving, it doesn't matter, right? Now, Q is the quality. So describe the pain. Is it dull? Is it aching? Is it throbbing? Is it piercing, right? Okay, R is region or radiation. So where does this pain occur? Does it go to other parts of the body? Does it move around, right? So point to where this pain is. Now, severity of the pain, that's what the S stands for. We want to use the scale of 1 to 10, really even 0 to 10, 0 being no pain, but 10 being the absolute most painful thing that they have experienced. So we want to understand what is their level of pain. If it is a pediatric patient, you may have to use the FACES scale. We do know have the Baker-Wong scale. We also have the pain scale for those that have nonverbal indicators of pain. So we're looking for grimacing, guarding, those kinds of things. But we want to be able to rate the pain on some kind of scale, okay? T stands for timing. Okay, does it happen when you're doing something else? Maybe it's associated with eating, with movement, or exertion. Okay, so that was the PQRST of pain. Now let's talk about past health history. So we want to know, have they had any major issues, any surgeries, immunizations? Are they up to date? Have they ever had any childhood illnesses, any kind of accidents, any kind of trauma? Because they could be living with the residual from any issues that they've had in the past. Okay, so that's going to be important. And so this emphasizes hospitalizations, surgeries, psychiatric or mental illness, and allergies. Okay, so when assessing your elderly, it's important to ask if they've ever had a polio, right? Because we know that your elderly patients are more likely to have had polio because maybe they were alive before the vaccine or they were not receiving the vaccine as children, right? So it's important to ask that elderly patient. And also because polio is a musculoskeletal issue and maybe they have assistive devices or they have impairments to their mobility because of polio. Okay. So, family history is going to be the next thing to talk about. And we know that family history is important because we get our genes from our family, right? So, we have to talk about if or ask the patient if there's any family history of any kind of disease, heart disease, cancer. So, those are things to ask. When we talk about the patient's current health status, we have to think about is the patient smoking, drinking? What's their nutritional status? Are they sedentary? Also understanding if they have medications. What are the current medications that they're taking? Sometimes patients will have a long list of medications, but they'll say, oh, well, I'm only taking this. And those medications that they're taking also include over-the-counter medications as well as herbal supplements, vitamins. So they may say herbs and berries, right? But we have to figure out what all of those things that the patients are taking. Okay, so when we talk about the review of systems, right, we want to go into a head to toe fashion. So let's start with our skin. Okay, so when we're assessing the skin, right, we're going to look for pigmentation. Is it appropriate for their ethnicity, right? We want to look for things like pallor, right, which is pale in color. Erythema is going to be some redness. Cyanosis is going to be bluing, right, associated with lack of oxygen. Jaundice, which is a yellowing of the skin, or the sclera, which is going to indicate liver disease. Freckles and moles, we want to see, are they new, right? Are they growing very rapidly? We're looking for size, symmetry, the border. We want the border to be smooth and the pigmentation to be even throughout. We're also looking at temperature, right? Or assessing the temperature of the skin. Hypothermia, hyperthermia, is the skin cool to the touch, right? Or is it warm to the touch? So we're also looking for moisture and texture, right? Is this patient's skin sweaty, right? That's your diaphoresis. Is their skin dry, right? Dry skin might be a sign of dehydration, especially in the oral mucous membranes, okay? We also want to see if the skin has any flaking, any edema or swelling, and if there is edema, we want to assess the edema. Is it plus one, two, three, pitting edema, right? And edema is swelling, and it's best measured on the shins, and we will depress the shin with two fingers and see how long that indentation of our fingers lasts, right? And that's going to determine the severity of the edema. Now, edema can get so bad that it actually starts to weep, and that is actually very painful for your patient. We also want to check out any bruising, right? And so when we think about bruising, we want to see, okay, are these new bruises? Does the patient have multiple bruises? Because if the patient comes in and they said, oh, I fell off of my bicycle, and they have multiple bruises, some are new, some are old, they're in various stages of healing, that could be a sign of potential abuse. Remember, we are mandatory reporters of child abuse and elder abuse. Okay, if there's any lesions, we will examine those lesions, and we will look for the color, the elevation, the pattern, the shape, the location, and any exudates. And exudates is a fancy word for saying drainage. We will also look when we're examining the skin if there's the hair, is it normal or is it dry? Is it brittle? When we look at the patient's lower extremities, are there patches of hair that may be missing, right? So we also have to look at the nails, right? The shape, the color, the contour, because you will probably learn or already know that if your patient has clubbed fingers, right, their nails are severely curved, that could be a sign that they may have congestive heart failure, or they may have COPD, right? But there's something going on with that patient, their circulation, their oxygenation. Okay, so skin is really an important thing to assess in our patients. All right, now we're going to jump to the neurological assessment. So, the neurological assessment is a detailed assessment, and I want you to think about your cranial nerves. So, I'm going to share this with you. This is the cranial nerve funny face guy. If you are having a test on the nervous system in the future and you know that the cranial nerves are going to be on it, you can definitely memorize this picture and draw it, and it will help you understand the 12 cranial nerves. So I like this picture also, the cranial nerve muscle guy, because it actually lists each of the nerves. So one, the nose, olfactory, makes sense, your sense of smell. Two, three, four, and six are all around the eyes, right? And so that deals with your eyes, your six directions of cardinal directions of gaze, right? Perla, pupils equal, round, reactive to light and accommodation. So this is what we're talking about when we have two, three, four, and six. Cranial nerve number five is going to be your trigeminal nerve, right? And that's on his face. Cranial nerve number seven are the sideburns, right? Or really maybe his hair. And those are the facial nerves. Cranial nerve number 8 is your acoustic, also known as your vestibular cochlear nerve, and it deals with your hearing. So you may be thinking, if someone has nerve damage to one of these cranial nerves, could that particular sense be affected? Absolutely. Right? So cranial nerve number 9 is the glossopharyngeal, and cranial nerve number 10, think vagus nerve, think internal organs. Cranial nerve number 11, your accessory, right? That's on the shoulders, and then 12 is a hypoglossal, the tip of the tongue. Okay, so that's just a quick blurb on your cranial nerves. But whenever you're performing this neurological assessment, you're going to be assessing those 12 cranial nerves. So that's why it's important for you to remember it. I know you learned it in anatomy and physiology, but it's important for you to remember it. Now, when we're performing our neurological assessment, we want to ask questions like, did they hit their head? Do they have a history of head injury or concussion? Do they have a history of headaches or migraines, dizziness, vertigo? Have they ever had seizures, right? So we want to ask all of those questions. When we are also looking at the neurological assessment, we want to find out, do they have any difficulty speaking, swallowing, coordination, numbness, tingling, right? Because that all deals with our nervous system. Okay, and also, are they exposed to any environmental or occupational hazards? So when we are assessing this nervous system, we're going to really focus on the 12 cranial nerves, right? So here's an image of those 12 cranial nerves, right? As kind of also depicted with the cranial nerve funny face guy. And we'll go past that, but if you don't remember this, please take some time to review it. Okay. When we are expecting the motor system, we are going to be assessing for muscle size, symmetry, strength, muscle tone. Is there any involuntary movements like a tick, a tremor, right? Are they protruding their tongue, right? So all of these things is what we have to take a look for. When we're examining cerebellar function, we're looking at the cerebellum, right, and its functioning. And so remember, that's the cerebellum is sometimes called the mini brain, and that provides for smooth, coordinated movement. You should also be familiar with the Romberg test. If you are not familiar with the Romberg test, please take some time to look it up and check out some videos of the Romberg's test. The patient will stand with their feet just slightly separated so they have a good balance, and they will have their arms at their sides, and they will close their eyes. You will stand with your arms extended to, steady the patient in case they start swerving or, maybe getting ready to fall. Right? But we will do this test, the Romberg test, for 20 seconds. You have to know what the Romberg's test is. When we check for cerebellar function, we're also looking at their gait. How are they walking? We're looking for rapid alternating movements, finger to finger test, and finger to nose test, and heel to shin test. If you're not familiar with those, definitely check out Registered Nurse RN. Nurse Sarah has some excellent videos with all of these kinds of assessments. Okay. Sensory system, we're going to be examining them and seeing if they can identify superficial pain, light touch, and vibration. And again, check out Nurse Sarah for this. You're also going to be looking at assessing the reflexes as well. Okay, we're also part of the neurological test is going to be for levels of consciousness, right? And so we're checking for motor function, for strength. Can they follow commands? We're looking for perla as well. So let's test ourselves. When we are checking our pupillary response, pupils equal reactive to light and accommodation. Should both pupils be the same? Yes, they should be symmetrical. There should be symmetry there. The other part that goes with the neurological exam is going to be the Glasgow Coma Scale. So this is really an important test, especially for your patients that may be unresponsive. Um, and I don't want to say unresponsive because that that means they need CPR. But your patient that is unconscious, right? Or a patient that appears to be in a coma. So unresponsive means that they need CPR, that there's no pulse, there's no breathing. So I just wanted to make sure that that was clear. So when we have the Glasgow Coma Scale, we are going to look for their eyes, their motor response, and their verbal response. So here's a chart that really tells you how it's broken down. You have to know this Glasgow Coma Scale. You have to understand what the components are and how to test. So when we talk about the eyes, can they open their eyes? So if you say, Mrs. Jones, please open your eyes, and there's no response, then they get a 1. If you pinch them and they open their eyes, they get a 2, right? Uh, wait, hold on, I'm sorry. Okay, so I just had to take a quick pause for a second. So let me go back to the Glasgow Coma Scale. So we're looking at the eyes, the motor response, and the verbal response. Okay, so we want them to have the highest possible score. So with 1, there's not going to be any response. When 2, they will get, if we pinch them, they open their eyes. 3, if we tell them, please open your eyes, they open their eyes. And then 4, they just open their eyes on their own whenever they're ready. Okay, so that's going to be 4 is going to be the best response. That's spontaneous. Motor response. So this 1 is there's no motor response, and 6 is going to be if they obey verbal commands. So here's an example. If we say, Mrs. Jones, please lift up your right arm, right, or lift your right index finger, and they're able to do that, right? So that means they obey the verbal commands. Now, you also have to understand, though, if Mrs. Jones' right arm is paralyzed, they're not going to be able to do it. So it could be something like wiggle your nose or something else, depending on what's going on with the patient. Okay. So we just have to kind of look at what the patient's status is, if they had a stroke or if there's an injury. So we have to keep that in mind as we're testing them for this Glasgow Coma Scale. Now, the verbal response, 1 is no response. And if they're oriented times 3, then they get the full 5 points. Okay. So when we think about orientation with our patients, is the patient oriented to self? Do they know who they are? And so to self or to person, to time, place, location, or situation. So do they know that, okay, my name is Colleen Ignacio and I am here at Virginia Beach General Hospital. It is, August 10th. And the reason why I'm here is because of X, Y, or Z. So that's what we're talking about when we talk about the patient's A&O times 3 or times 4. Okay, so let's jump out of the neurological assessment. Let's go to the head, face, and throat assessment. So again, we're always going to be looking for symmetry. We're going to ask the questions, do they have any headaches? Do they have any history of head injury? Do they have any dizziness, pain, swelling, lumps, or bumps? We're going to be looking for facial hair, right, distribution. Do they have facial expressions? Because with some conditions, they will not be able to have facial expressions. They'll have what we call a flat affect, right? So these are all things that we have to look for. They may have, if this person is a stroke survivor, CVA, a cerebrovascular accident survivor, they may not be able to smile. One side of their face may be drooping. So these are all things we have to look for. So when we are looking at the eyes, is anything changed with their vision? Do they have any eye pain, double vision, night blindness, history of glaucoma? Do they wear corrective lenses? Where are their corrective lenses, right? With the assessment of the eyes, you may have to use the Snellen chart, and that is also, when we think about that is the visual acuity test. So for your pediatric patients, we won't use the Snellen chart that has letters. We will use one that actually has symbols or shapes like a sailboat, a cat, or a rubber duck, right? So that's tailored because the pediatric patient may not know their alphabet yet. Okay, so when we're looking and examining the eyes, we're looking and examining those cranial nerves that are appropriate with the eyes. We're looking for things like nystagmus, right? Is there an abnormal moving of the eye rapidly from side to side? We're looking at the conjunctiva, right? If we pull down the lower lids of our eyes, is it pink and moist? The sclera, the white parts of the eyes, maybe they're not white. Maybe there's a lot of blood vessels. Maybe it's yellow, right? And that will be called scleral icterus. So we're looking for all of these things when we are examining the eyes, okay? There should be a red reflex in the eye, right? And usually you have to really have specialized training because sometimes not all providers understand how to check for the red reflex. But the red reflex is something that should be there, okay? When we are looking at the ears, we have to ask if they have a history of ear infections. Do they have any drainage or discharge in the ears or coming from the ears? So here's a quick sidebar. If you have a test question and it says this patient is a head trauma patient, then now they have clear fluid either draining from their eyes, nose, mouth, or ears. I am thinking this is cerebral spinal fluid. The way that I can confirm it is I will test for glucose. If it's positive for glucose, then it is cerebrospinal fluid. So that's just a quick sidebar because I've seen a lot of questions surrounding that kind of thing. Okay, so when we talk about the ears, do they have any hearing difficulty? Do they have environmental exposure? Do they have ringing in their ears? Do they have dizziness? Because remember from anatomy and physiology, the inner ear actually helps us with our balance as well. Okay, so when we talk about the ears, we're also looking for the skin, the shape, the condition, or is there any tenderness, swelling, discharge? The tympanic membrane should not be red, right? It should be a pearly gray color when we look and we inspect that tympanic membrane. Also, hearing acuity can be performed. Maybe there's audiometry that has to be done. A hearing test has to be performed based on why they're in your office. Now let's talk about the nose. Is the nose symmetrical? Do they have any discharge? If so, what color is it? What is the consistency? We know that any discharge or exudate, right, is going to, if it's brown, yellow, green, malodoriferous, that's a sign of infection, okay? Does this patient have frequent colds? Do they have sinus pain, right? Do they have nosebleeds, also as known as epistaxis? Real quick, what is the first aid for nosebleeds? Tilt the head forward, not back. Tilt the head forward, pinch the nose, apply pressure for 5 to 10 minutes. If that doesn't work, apply ice pack. We're applying ice because that causes vasoconstriction of those blood vessels. We don't have the patient hold their head back, and you could see this for test questions because the blood from their nose can actually be an aspiration risk, or it could go into their stomach and cause them to vomit. Okay, so that's why we don't have the patient hold their head back if they're having a nosebleed. So we also want to assess for allergies because a lot of times if your patient has allergies, when you look inside of the nares, they could be red and swollen, right? So we want to check that out. Also, does this patient have a change in sense of smell, right? That's going to be something significant as well. So when we are looking at the mouth and throat, because we're moving on down, right? We are looking at skin integrity, lesions, blisters, teeth, right? Does the patient have any loose teeth, rotting teeth? Because those can be aspiration hazards, and for sure they're going to affect the patient's nutritional status. We're looking at the tongue, right? We're looking for any moisture, lesions, and we want the oral mucosa to be moist because one of the ways that we can best check our patient's hydration status, especially in your geriatric patient, is the oral mucosa moist? Okay, so that's going to be important. Is the uvula midline? Do they have their tonsils? Maybe their tonsils were surgically removed, right? So we have to ask all of these questions. Do they smoke? I'm sorry. Do they drink alcohol? Smoke cigarettes? Or chew tobacco, right? So these are all things to think about. And also, do they have bleeding gums, right? Do they have any sore throat? Okay, so now let's jump into the cardiovascular assessment. So this is another big system. We've got to ask the patients, do they have any chest pain, shortness of breath? How many pillows do you sleep on at night? Why is that significant? You're definitely going to see that come up again. And what I want you to know is orthopnic position, orthopnea. What does that mean? The patient has to sleep upright, sitting up, right? As if they were sitting up in a chair. Sometimes the patients will have pillows piled up on their bedside table, and they cannot sleep because when they lie in the supine position on their backs, they cannot breathe. Okay, that is very significant. And you may be saying, okay, I got that. Okay, they need to sit up in order to breathe. So what does that mean? That means that this patient may have congestive heart failure. They have fluid volume overload, so they may feel like they are choking on their own secretions at night, right? Or maybe that fluid is backing up into their lungs if it's a left-sided heart failure. But you're going to see the orthopnic or orthopnea. You're going to see that again and again, so I need you to know that now. You're going to ask about a cough. Do they have sputum, right? Is it blood tinged? Because that's going to also be a sign of left-sided heart failure. Do they get frequently fatigued? Okay, again, these are all things that can indicate the patient may have congestive heart failure, right? Do you get up in the night to urinate? That is nocturia. Whenever you see urea, think urine. Think nocturnal, think nighttime. Okay, have they had any past cardiac events or history? Does their family have a history of cardiovascular disease? We want to assess all of those risk factors, right? And again, smoking cigarettes, chewing tobacco, vaping, all of that, sedentary lifestyle plays a role in their cardiovascular health. So when we assess this when we perform this cardiovascular assessment, we're going to be looking for um, jugular venous distension. This must be performed when the patient is sitting at a 45-degree angle, and you can actually see bulging jugular veins. If you're not sure, I want you to Google JVD and look at that picture. You're going to see some videos on JVD because once you see it, you'll know what it is. You will not forget it. All right, so you're going to palpate and auscultate the carotid artery. You're going to be using the bell of your stethoscope, and you will only do one carotid artery at a time because your carotid artery supplies blood flow to the brain. So if you occlude both of your carotid arteries, there's not going to be any blood flow to the brain. Okay, so we don't want you to do that to your patient. Okay, we're going to inspect the precordium. So this is going to be on the left side of your patient, right? Where they have the PMI. So that's the point of maximum impulse. And so what are the landmarks? You need to know this. Left mid clavicular line. So the left clavicle, we're going to go to the middle. Fifth intercostal space. We're going to count those spaces. 1, 2, 3, 4, 5, right? For women, that's usually where the left breast is, right? And so when you get to that spot, you're going to inspect. Are you going to see any heaves and lifts? So can you actually see the patient's heart beating, right? Can you actually feel it beating? Okay, if you're not sure, I want you to go onto YouTube and Google heaves and lifts for the heart. And when you see it in a video, you will not forget it. Okay, so you will also listen to that same spot, left intercostal, left midclavicular line, fifth intercostal space. You'll place the diaphragm of your stethoscope and you will listen for a full 60 seconds, and that is the apical pulse. Okay. Are also going to percuss the cardiac borders auscultate the heart sounds. Okay, so if you're not sure about the heart sounds, when I post this, I'm going to post some links for listening what the S1 and S2 sounds should sound like, but you need to be familiar with that. You also need to be familiar with the S3 and S4 sounds. Those are extra sounds. Those are not necessarily normal sounds. S4 is always going to be pathological sound. The S3 sometimes may be a normal finding. It's not necessarily a pathological sound, but the S4 is always a pathological sound. Okay, but the S1 and the S2 are normal heart sounds. Okay, so I want you to listen for murmurs, and of course, you're not going to know this just by doing it one time. This is going to take practice, 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 practice. Okay, you're also, as part of the cardiovascular assessment, you're going to be checking out your peripheral pulses. You're going to be palpating the pulses. You have to know where all the pulses are located, okay? From head to toe, you have to know where to find them, and you have to know the significance of each of the pulses, okay? You're also going to check for color, cap refill, edema, ulcerations. Cap refill is super important. You take the tip of your finger, squeeze it, and it should go from pink, right, to maybe a white color, depending on your ethnicity. But the normal color should come back within less than 3 seconds, right? That's going to be a successful capillary refill assessment on your patient, okay? All right, so a lot going on with the cardiovascular assessment. Let's jump right into the pulmonary assessment, okay? When we think about pulmonary assessment, we also want to think about the PQRST of pain. Do they have a cough? Are they short of breath? Do they have any pain when they're breathing? Do they have a history of lung disease, right? So we really want you to listen to the lungs, auscultate the lungs, okay? So, of course, we're always going to inspect first, right? We're going to be looking for symmetry. We're going to be saying, okay, is one side of the chest moving up and the other side not? We're always inspecting for symmetry, right? When we auscultate, we're going to be seeing if there's any adventitious lung sounds, okay? That's going to be important, okay? We're going to palpate, percuss, and then auscultate. So that's the order that it's going to be in. Inspect, palpate, percuss, and then auscultate, okay? When we auscultate or when we listen, we have to listen to the anterior, which is the front of the chest, and then also listen to the posterior. So these pictures here give you a clear idea of what you should be doing as far as listening on the left and then to the right and then moving down, right? It's a kind of a zigzag pattern. Don't forget your lateral lung sounds. So those are lateral, meaning the sounds on the side. So don't forget that. Okay, assessing the abdomen, the GI system, okay? So everything from the mouth to the anus is going to be your GI system, okay? So we're going to ask a lot of questions: change in appetite, difficulty swallowing, abdominal pain, nausea, vomiting. What are your bowel habits? Do you have any hemorrhoids, any history of abdominal problems, right? So when we assess the abdomen, we must remember where the organs are located, right? Because we have these quadrants, so we have to understand that. Remember, with the abdominal assessment, the order is going to be different. There's always test questions about the GI assessment and the order in which we assess. So inspection will come first, auscultation will come second. Okay, percussion will come third, and then last, palpation. Okay, so you've got to know that order. That's really, really important, okay? Because I've seen many questions on that. And when we are inspecting, we're looking for any lesions in the skin, ascites, round protuberant abdomen, right? And if you don't understand any of these words that are being used, that's okay. look them up in your textbook. You can Google them, ask your classroom instructor. They're going to be more than happy because that tells them that, hey, they're reading, they're thinking critically, right? They're self-directed learners, and that's what your instructors want to see. But so we're inspecting, we're auscultating, we're percussing, we're palpating, right? If the patient complains of pain, tenderness, obviously that's not going to be a normal finding. That's something that we have to definitely report or investigate a little further. Okay, so I'm going to continue on to the musculoskeletal system. We're looking for range of motion. We're looking at the joints. We're testing muscle strength. A lot of the assessment for the musculoskeletal is going to be similar to what we saw in the neurological exam as far as muscle tone, symmetry, that kind of thing. We're also going to be assessing the spine, right? We're going to be looking out for curvatures of the spine. So lateral curvature of the spine is scoliosis. Kyphosis is what we would see with a hump back, right? A lot of times it's present in your geriatric patients, and that could be pretty dangerous because it changes their center of gravity. Also, there's lordosis, which is a curvature of the lumbar spine. That is a normal finding in your pregnant patient, okay? Maybe sometimes your patients that have ascites may also have lordosis, right? Now, your pregnant patient, once they deliver, that lordosis should be corrected, right? Okay, so here's a test for yourself. When testing the musculoskeletal system, you should test muscle strength and the strength against resistance of the other major muscle groups. Well, yes, that is true. That is absolutely true. All right, let's jump into the male reproductive system. Okay, so reproductive system, you're going to ask, you know, about urinary frequency, urgency, nocturia for both your male and female patients. You're going to ask about burning, any dysuria, right? Difficulty urinating, any blood in the urine. For the males, you're going to ask, is there any problems with your penis? Are there any lesions, any discharge, any problems with the scrotum, right? So males starting at the age of 15, right, they should be starting their monthly self-testicular examinations, taking their hand and actually rolling the scrotum between their fingers to see if there's any lumps or bumps. Okay, that's going to be important. We ask about sexual activity, contraceptives, right? Those are all things to ask when we're talking about the male reproductive system. Okay. All right, we're also going to be looking out for hernias, looking at their lymph nodes, their inguinal lymph nodes, and there are different types of hernias. Look in your textbook and see the different kinds of hernias, okay? Because that's something that we will have to check for and assess, especially in our male patient. For the female reproductive system, we're going to ask the same questions about urination. We're going to ask them if there's any vaginal discharge, if they're sexually active, do they use contraceptives. We're going to ask them about the onset of their menstrual cycle. When did they have their first period, right? Menarche. If it's an older woman, maybe she has already gone through menopause, maybe she's currently going through menopause. Have they had any pregnancies? If so, how many living children? How many miscarriages have they had? How is their menstrual cycle? Is it regular or irregular? Also included in the female reproductive system is going to be their breast exam. Are they performing their monthly self breast exam? Here's a great test question. The woman is performing her monthly self breast exam. When is the best time to do it? Well, if this is a post-menopausal woman, meaning that she no longer has a menstrual cycle, the timing doesn't matter. She can pick one day of the month and say, okay, on the first of the month, I'm going to do my self-breast exam. If this is a woman of childbearing age that has her monthly menstrual cycle, the best time to perform the self-breast exam is going to be 7 days after the end of the menstrual cycle. So the last day of the menstrual cycle, we wait 7 days, and that's when they should perform that self-breast exam. If you see a question that says 2 to 3 days before the menstrual cycle, that's not going to be the right answer because 2 to 3 days before the menstrual cycle, the breasts are tender. They could be swollen, right? That is not the best time to perform the self breast exam. Okay. The other thing to ask your female patient, right, is how often do they have their regular pap smears? They will start having pap smears when they become sexually active or at the age of 21. Okay. So we will also assess the female genitalia, looking for hair color, um, skin color, sorry, hair distribution. Are there any swellings, any lesions? Is there any discharge, right? We're going to look for any issues with their Bartholin's glands, right? So all of this is important, okay? Now, as registered nurses and practical nurses, we are not going to be checking anybody's cervix, right? That's not what we're going to be doing. Specialized training is done for your labor and delivery nurses as they're checking the cervix to see if it's dilated, but that's not something that we are going to be doing in our practice, okay? Another part of your health assessment is going to be nutritional assessment, right? So these are the things that test questions are made of. When we talk about a patient's nutritional assessment, albumin, albumin, albumin. Albumin is the protein that helps the blood stay inside of the blood vessels. If your patient has low albumin, the all of the blood is not going to stay inside of the blood vessels. We're going to have some of that liquid leaking out, thus the edema, right? If your patient is also low in albumin, that tells me that they don't have enough protein, they don't have a good nutritional status, and they are what we possibly will call malnutrition. Now, it's possible for someone to be obese and malnutrition because they're not getting the appropriate vitamins. If they're eating a lot of junk foods, right? And they can be obese, but that doesn't mean that they're getting the appropriate vitamins and minerals. Other lab data that's going to be important is your hemoglobin and hematocrit, and also their lymphocytes. So you've got to know your lab values, okay? You have to know your lab values, okay? So when we look for nutritional assessment, we're looking at the eyes, their skin, or is it dry? Do they have cracks at the side of the mouth? Because this is a sign of that can be a sign of vitamin deficiency. Pale bleeding gums. So I think of scurvy and I think of pirates. I think of vitamin C deficiency, right? Dry, flaky skin, petechiae, which is those pinpoint rashes, is there bruising, right? All of these could be signs, right, of nutritional deficiency. Do they have dull, dry hair, brittle nails, muscle pain, muscle wasting? Right? Splintering nails, those are all things that we have to understand that may be as a result of malnutrition. Okay, again, lab values, you definitely have to know that. Okay, so I think I have given you a fire hose of information, right? But you have to be able to put all this information together in order to understand what's going on with your patient. Okay, so this is what we do as nurses. I want to thank you for your attention to this video, and if you have any questions, please reach out to your classroom instructors, reach out to any instructor, because this is going to be really important for you to understand, because this is what we do. We assess our patients every single day, every single shift. You can do it. I know that you can. Always, always, always think like a nurse. Thank you.